Good morning, everyone. So the topic given for me today is workup of a refractive surgery patient. So as we all know, refractive surgery is gaining more popularity nowadays because it provides spectacle independence and it is predictable and efficacious, and more than 90% are attaining within the intended correction. So these are the procedures nowadays we are commonly doing. So counseling is of utmost importance because we have to meet the needs and expectations of the patient. We should explain the patient that there is a chance of severe dry eyes and glare and halos post-procedure. Especially in patients who are in the presbyopic age group, the ocular comorbidities which might happen post-procedure should be explained, and a detailed written informed consent should be taken. Preoperative evaluation is very essential, especially the profession of the patient, because there is a risk of flap dislocation in patients involved in contact sports and in people who depend on their day-to-day living because of their near work. If we are giving a complete emmetropia, they may not be happy because they will be lacking the efficiency. Also, we have to tell them there is a risk of flap dislocation, there are risks of infections, and there is risk of post-operative dry eye. Contact lens usage should be discontinued prior to the investigations. The patient should achieve refractive stability, which is within 0.5 diopters in the last 6 months. We have to avoid refractive surgery in postpartum and lactating women. Drug history should be taken into account. So this is the FDA approved age limit for each procedures. In systemic history, medication history is important because certain medicines like hormone replacement therapy, sumatriptans, retinoids can affect the wound healing and collagen metabolism. Then in patients with immunodeficiency like HIV, the procedure is contraindicated, but still if the patient is insisting, we can take universal precautions. Then patients with uncontrolled diabetes mellitus, we have to exclude them from the procedure. Examination should involve visual acuity, and in cycloplegic refraction should also be done. If there is any scissoring reflex and underlying ectasia should be suspected. Ocular dominance, especially in presbyopia, is important because you have to provide them with monovision if required. IOP measurement and glaucoma evaluation should be done. The clinical examination begins when the patient walks into the room. We have to check whether there is any prominent nasal bridge, prominent brow, any active vesicle suggestive of herpes, any ocular misalignment should be tested with and without the glasses. Ocular surface evaluation should be thoroughly done. Any pterygium, any significant central corneal opacities, ulcers, significant neovascularization of the cornea, especially reaching till the center, any severe endothelial dystrophies like Fuchs, any central epithelial basal membrane dystrophies, all should be evaluated. Any blepharitis, dry eye disease, meibomian gland dysfunction should be treated. Post-operative examination should be detailed done. Any suspect patients, ocular hypertension, glaucoma should be evaluated. Prior procedure, perimetry should be done. Any lattices should be lasered 6 weeks prior to procedure. Also, tear film assessment, both quantitative and qualitative, should be done. So this is a non-invasive tear breakup time taken in our machine. There is risk of post-operative dry eye because there is denervation of the corneal nerve fibers, and it will take some time for the nerves to regenerate. So these are the detailed investigations which we do, including biometry, topography, pachymetry, pupil assessments, specular count, anterior chamber depth, white to white, etc. So this patient visited our clinic to undergo laser vision correction. So on evaluation, we saw that there is a thinning of the cornea in the center. The thickness was around 319 micrometer and the central power were very high. So that was a keratoconus patient. We deferred the procedure. This is another patient which visited our clinic. Even though altogether it looks okay, but still the thickness of the central cornea is 482 micrometers. So we told them preferably undergo an ICL procedure than a laser vision correction or surface ablation. Also, when we look at the CTSP map, we can see that the center is going like almost. Sorry for that. So here this arrow is going almost outside the line, and here also it is a borderline thickness, so preferably ICL. Also here the central 3 points, pupil, the thinnest pachy and the apex, everything is crowded. So not a good candidate for a surface ablative procedure. Now white to white and anterior chamber depth are important because in planning, especially in ICL patients, so there are various methods of determining the white to white length. We can take the ICL sizing with a caliper. So caliper can be used from in the gray zone, mid-gray zone, from 3 to 9 o'clock position. AZD is important because a high volt and a low volt both can cause postoperative complications. So this is the manufacturer's online calculating system and ICL sizing depending on the white to white and anterior chamber depth. Pupillometry is important because a very big pupil size at night can cause edge effects, that is scotopal pupil size. It can cause glare, halos, higher order aberration, commas, etc., which will be discomfort for the patient post-procedure. So this is the infrared pupillometry taken from a laser machine. It shows both the scotopic pupil size, mesopic pupil size, also the photopic pupil size. So wavefront analysis is nowadays being used. So aberrometers are used to determine the ocular aberrations and to provide customized treatment plans. So who is a suitable candidate? Age within the recommended age group with the stable refractive error, expectations explained, and there are no contraindications. So there are both absolute and relative contraindications. If the patient is having severe dry eye, uncontrolled glaucoma, severe diabetes mellitus, very low specular counts, pregnant and lactating females, the procedure should be avoided. So after preliminary examination and investigations, we can classify whether the patient is apt for a corneal-based procedure or a lens-based procedure or bioptics. So the 10 commandments I would like to summarize are proper counseling, detailed ocular history, assessment of the systemic status, treatment of any allergies, dry eye disease and systemic condition, a thorough posterior segment examination, detailed investigation, avoiding the procedure in people prone to develop retinal detachment and glaucoma, select appropriate procedure, patient adherence to the treatment protocol, and also the doctor should be available long term to attend to the patient's concern. Thank you for your patient listening.
Thank you, Dr. Sandton. It was an excellent talk.
Thank you.